Okay.
All right. So I'm Charles Macias. I'm the co-principal investigator for the EMSC Innovation and Improvement Center. And our topic today is quality improvement, specifically looking at data as we think about how we're using data in our various projects. Just a sound check here. Is the background noise distracting, or are you okay with what you can hear?
Okay, I can hear.
Okay, great. Then I'll go ahead and move on. So why do we collect data? Obviously, it's because we really want to be able to understand the systems that we are working with. And I'll just give you an example of one of our big stories. And when I say our, I'm referring to my hospital, as all of you are going to represent a system or a set of systems or project efforts. So our big story really started in 2015, where out of the 14,843 babies that were born in Cuyahoga County in 2015, 156 of those babies died before their first birthday. So that implied that the infant mortality rate was 10.5 deaths per 1,000 live births. That was a 30% increase from the year prior, which was 8.1, and nearly 3 times the national average. So a lot of this work recognized the importance of data to create the context. And as that drill down and alignment of data with the various entities that were concerned with that infant mortality rate noted that sub analyses discovered that Black infant mortality was running about 3 times the rate of white infant mortality. So two things really emanated from the work. The first is First Year Cleveland, and that was the development of a grassroots set of organizations that were brought together, led by 2 hospitals, Rainbow Babies, the hospital that I represent, and Metro Health, to create the First Year Cleveland program. It launched in December 2015, really to achieve social change around all of the entities that were involved. The second big program was that Rainbow created a new center, which was the Ahuja Center for Women and Children. And in that center, 95% of the patients that we serve identify as Black. They come from a 5-mile radius of the center, of which many of those neighborhoods were redlined areas. And so really big food deserts, limited income in those areas. In fact, 90% of the patients that are served by the new center are either publicly insured or uninsured. And that center creates wraparound services, providing both pediatric and OB care, lab, optometry, dental, legal, nutrition, employment services, even partnering the nutrition part with the build of a new supermarket, Dave's Market, which has a test kitchen and a teaching kitchen, and teaches many of the families on limited budgets how to shop and how to cook healthy on their budgets. And so it's really nice services that are created, also including centering pregnancy, which carries mothers with doulas through their pregnancy. Data was important to understand, are the processes in place? So we were seeing increased volumes of patients served in the center and services delivered through dental, optometry, and pharmacy prescriptions in those wraparound services. Outreach was happening by the thousands, and you can see in these data over 17,000 outreach events that connected many of these families with the needs that they specifically had. Data was also important to represent success of the program, that the centering pregnancy mothers there through First Year Cleveland support plus the support of the center had half the preterm delivery rate, as well as half of the rate of babies born at a low birth rate. So being able to carve out that data as antecedents to infant mortality, we saw infant mortality drop to its lowest rate in 30 years in 2020 with those 2 efforts. Critical to all of that was data to display, data to understand each of the processes, data to understand the structure, and then finally data to understand, are we achieving the outcomes that we needed to achieve? So we think of the work with data in phases of data. So exploratory data analysis, for example, helps us to understand in the planning process for our projects, also helps us to summarize and describe visualizations. We'll talk a little bit more about the key driver diagrams and how we define populations and measures as we go later into that, but just wanted to explain that difference between the exploratory phase and then our formal QI reporting. How are we reporting on processes? Are the processes, which are the encounters with families, the encounters with the system, are they proceeding the way that we anticipated? And then ultimately, is that leading to the outcome? So we'll talk more about specific scorecards and statistical process control charts, but not go into a lot of detail on that, but talk about that with visualizations. So much of what we talked about in quality improvement is using the model for improvement, asking the question very clearly, what are we trying to accomplish? Creating measures so that we then say, how do we know that the change is an improvement? And then determining through plan, do, study, act cycles, are we making interventions that are that we put into planning, then do them? Then on the study phase, we look at our data and say, do we act on that data by adopting those changes? Do we iterate the interventions that we've created, or do we completely abandon those interventions? So 3 options as we move through a plan, do, study, act cycle. We also recognize that there are various types of data. Like we have categorical data, which is a type of qualitative data. These are descriptive. They can be things like race, religion, sex, gender. They're non-numerical. In contrast, quantitative data is the measurement data or numerical data. And so some examples of that are height, weight, and you can see qualitative data examples below as examples of height of a person. Qualitatively, that would be short. Quantitatively, that would be 150 centimeters. Qualitatively, outdoor temperature could be hot or cold. Quantitatively, it would be 90 degrees Fahrenheit. IQ scores. Qualitatively, we could say that person's a genius. Quantitatively, that might be 167 as an IQ. So we can drill down to quantitative data to talk about continuous data. So that's infinite possibilities for continuous data like height, weight, blood pressure, cholesterol. Discrete data is countable in a finite amount. So that's, for example, the number of beds in a hospital, the number of RSV cases, the number of mental health screenings, the number of ED visits for suicide. That gives a more discrete quality to that data. So our steps of a data analysis are we define the problem, we collect the relevant data, we prepare the data for analysis, we determine how we're going to approach the way that data is visualized, and then we interpret the results, and that's the data to insights piece. And we'll drill down a little bit into each of these. So by defining a problem, we have a global aim, and that's in this example, acute myocardial infarct. Your goal here may be to reduce the adverse event and mortality rates. We'll have some more very specific to PMHCAs, but you might also consider an aim around reducing the number of suicide attempts in a population identified to be at risk. So that would be a global aim. A SMART aim would be very specific. So here in this example, increase the rate of early use of aspirin in hospital acute myocardial infarct from 30% to 50% by a specific date. So SMART, so specific, measurable, achievable, realistic, and timely. We might take that same global aim that we talked about by saying we're going to decrease the rate of presentations of suicidal attempt in the adolescent population from 30% down to 12% by December 31st of 2023. So that's applied to the suicide population. So you can see the difference between a global aim, much higher level, SMART aim, specific, measurable, achievable, realistic, and time constrained. Then we want to collect the relevant data. And so measures allow us to focus on one issue at a time. So measures should be very specific. We want to define and refine what we have identified as the required data elements, and we want to create operational definitions of the measure so that we're very clear to everyone that when we talk about suicidal attempts, the emergency department visit may be the visit primary, secondary, or tertiary code for that visit. So we're clear that we're defining that measure of suicidal attempt by the diagnosis code captured in the emergency department. Then we want to review the definition to identify where specificity is required, meaning exactly if we're going to be valid in our definition, do we need to be so specific that we then say, these are the ICD-10 codes, the codes that are used that will define suicidal ideation, and only those, so that it doesn't depend on someone making an interpretation, well, was that or was that not a case that I would include? Then we want to identify the data sources. So in that example, I may say that my billing codes for the emergency department will be my data source, and that will be the relevant data that I would extract from. So then we develop our improvement project. We take our basic information and we name it. We create our measures. What's our process measure? Like, what is the measure of saying that, did I impose that intervention correctly? So in my example of the suicidal ideation piece, maybe it's education for providers on how to document and screen for suicidal ideation. So my process measure may be what percentage of the providers received the appropriate training, or the actual process of screening may be what percentage of patients were screened with the correct screening tool for suicide. The outcome measure would be what I'm trying to achieve to change the clinical outcome. There it might be, did I reduce, like what was the rate of suicidal ideation presentations? Did I achieve that 20% reduction or 30% reduction? And then a balancing measure is a measure that says, if I implement some change, what is the potential for it to be disruptive? So if I implement a screening tool, my balancing measure may be, what are the number of patients that leave without being seen because it now created such long waits in the emergency department that patients are leaving without being seen? Or I might directly just measure what are the length of stays in the emergency department because I've imported this or implemented this new strategy at screening. I want to have an operational definition of our measure. So your data elements are going to have a numerator and a denominator. So for the outcome measure, what is the total number of patients seen in the emergency department that year? That would be my denominator. My numerator there would be, what are the total number that had primary, secondary, or tertiary diagnosis ICD code of suicide attempt. And then I need to be clear on which patients are being included, which are being excluded. So only emergency department visits, we're excluding all other visits to any other place in the hospital. And then I may want to define my units per visit, per patient days. So there I said per annual number of patients seen for my outcome measure of reducing emergency department suicidal ideations in the adolescent population. Then the measure administration. Where is the data located? How do I sample? I have to know where it's held. And we said, this was billing data. So where is that held? What are our baseline comparisons? How frequently will I measure it? These are all specifications of how you're going to manage whatever you're measuring. It's really important as you consider your measure that you eliminate ambiguity. How did we do that with that measure around suicidal ideation? We're very clear. It's only these ICD codes that we include. We're not saying any interpretation of anything that isn't one of those diagnosis codes that was built. And then we can have specific considerations for exactly how structured data elements exist. So if it's the ICD codes that we said earlier, we know exactly what numbers they are that we're matching it to. For any time-based metrics like length of stay, we really want to define what is the beginning, what is the end point to that time measure. So an annual, per annual, we may want to be specific. Is it the annual as in the year, or is it annual as in the fiscal year? In our fiscal year happens to be our annual year in the hospital I worked at before. The fiscal year began October 1st and ended September 30th. So I may want to go with my fiscal year, but being clear on the time-based metrics is important. And then clearly define our cut points for inclusion and exclusion. I said adolescent. What do you guys think of when I say adolescent? We have to be explicit. Are we saying 13 to 18? Are we saying 13 to 17? Are we including older adolescents like 16 to 18? So it becomes a little challenging if we're not very clear on our inclusion and exclusion. And then we want to be specific to our data sources. I mentioned that before. We want to map the required data elements and saying exactly where is it coming from? Is it coming from the electronic medical record? Is it coming from a billing record? Is it coming from a state registry? So you have lots of options when you start looking at mental and behavioral health. And you're looking at data registries for the state. You just have to be very accurate as to how it's extracted and where you're pulling that data from so that it always remains consistent. So some things to consider for how you can find data and collect data. Administrative data claim system. So that can be things that you find in hospital institutions or in state records. Medical record systems are great for collecting this kind of data if they're built correctly. So you've got to make certain that the bill that you're extracting from is always capturing data the same way. That's the concept of reliability, that it's capturing the right kind of data. That's the concept of validity. Registries can be very helpful if you are part of a collaborative, for example, like ED Stop, then you may have a data source that you could pull out of ED Stop to be able to describe whatever project you're working on as a data source. Chances are, however, because so much of this is state-driven, that a state registry is going to be your better choice. Surveys and interviews. You can build your own data platforms using things like SurveyMonkey or RedCap or Qualtrics or Google Forms, or you can leverage existing survey data. And on the hospital side, things like satisfaction with Press Ganey or other kinds of national data sources. And then national databases outside of that, there's a number of existing data sets out there. HRQ even collects a number of data sets of which they have behavioral health visits included in some of those. So if you're looking at comparator data, you may want to go into some of the HRQ data sets to look for some national comparison data. All right, I'm going to stop there and ask you guys, who are some of the places that you're currently using data and where are you pulling that from? Anybody want to share a couple of examples or an example? Well, let me ask you guys for the how are you capturing or how are you describing the success of a PMHCA project? Are you able to define the number of patients you impact?
Hello?
Yeah. Yep.
Hi, everyone. This is Michael with the Tennessee PMHCA program. I'm the data person, data manager. And so what we're doing is we're capturing our data in RedCap. We started collecting data April this year, so we're fairly new. But we're using RedCap to capture things like number of patients, information, why they're calling, the essential stuff that we need not only for reporting, but to speak about the success of our program. So we're in the infancy stage. So like I said, using RedCap data and data from our partners that are doing the training, they're training the pediatricians. So like I said, we're mostly preliminary. So we're not where I guess you're at or you're speaking about.
And what I was really trying to describe is like all the opportunities to use data. And I love your examples. Those are perfect, right? Because you're collecting qualitative data because you're perhaps creating a medical record number or some kind of number or a name, right? So some way to identify that, and then you're creating quantitative data because you're creating aggregate numbers and able to say this is the number of patients per month or the number of patients per, what is the unit measure that you're using to describe your success? Is it per year, per month?
Right now, per month.
Per month.
Per month
So
right now. It'll probably be
those
per
are-
year eventually. And
Yep.
then to add to what you're saying, we are using we created like a unique identifier for the patients, so we can keep track.
Keep track of them. Yeah. So I love your examples. Those are perfect examples. And in that example, you're using your own. So the third row down there, you building your own through REDCap, as opposed to leveraging existing, because it's important that you identify your own data. If you ever wanted to go back and compare in a collaborative model, for example, we should all be able to then create aggregates. And this is something the EIIC can help support as we're moving into the year 2 of our work. So how does that compare? What are the nuances that define volumes in one area versus another? Are you seeing patterns with certain ages? So I think there's a lot that can happen as we move forward with our data processes. So as you think of those examples of, okay, so when are you seeing them? How are you seeing these patients? Like, are there times of days? We start talking about how are we going to visualize our data? How are we going to...
We have a comment in the chat. Sorry, I just wanted to make sure we don't miss it.
Do.
So Heidi chimed in and she's saying that they're using Triad software to capture the data used in their child psychiatric access program, PMHCA reporting.
Oh, wonderful. And how, what kind of data elements, Heidi, if you want to put that into the chat, just an example of a type of data that you're collecting for your access program.
Yeah, I can just tell you, so this is all practice level data, not necessarily, we don't have patient, we don't ask for patient identifiers, but necessarily, but some of the things we capture mostly monthly are the clinic type. So type of practice is registered.
The qualitative data with clinic type. Cool.
Yeah. Well, also the provider type that's referring, the consults per month. So these are all qualitative. The purpose of the consult, which is more qualitative, age of patients, quantitative, race, ethnicity, patient gender, severity of problem, which is quantitative, complexity of providers question, general knowledge of mental health, comfort level delivering recommendations, providers comfort level delivering recommendations, and then the counties, how many calls per county, that kind of thing.
Those are great. I'm going to take one example of the complexity of how we consider data. So one that you described as a comfort level. So you can make broad qualitative data more quantitative if they were capturing that kind of data as open-ended. Then a provider may just say something, and that makes it a little harder to analyze. But if you said your comfort level on a scale of 1 to 10, and they gave you a numerical value, then that's something measurable over time, so it becomes quantitative. I'm just curious, how do you capture that particular data element?
We have the categories on comfortable, comfortable, somewhat comfortable, and very comfortable. So not
that's perfect,
but
Yep. And you can, that makes it in such a way that you can analyze it, because if it's open-ended, it becomes really challenging.
Oh, so, yeah, no, it's not open-ended, but certainly not, again, like you said, numerical.
Yeah, no, these are great examples. Yeah, you guys are doing a ton of data stuff. Well, the way that we think about visualizing data then is, and so I'm going to take the example of the comfort level. We can begin to say, all right, so what is the most efficient way to describe comfort level? And one way that I could think about it is I could think about the way that people will react to it by showing before and after. So maybe a bar graph showing that comfort level increased by the proportion that felt in the highest category or the top two categories. And that might be a way that I would want to visualize it. The point of thinking about the comprehension that you're trying to achieve is that you're really trying to process the brain's ability to grasp the concept. Humans can process visual images 60,000 times faster than they can process text. So that gives you the compelling reason for why you want to spend some time thinking about how you're going to visualize your data. There's also better representation of complex data problems when you have the right kind of data display. So little fun fact there, our working memory capacity is about 5 to 9 items. So if you start chunking groups together, it makes it easier to process when you think about it that way than to have 1,000, different bars there on a bar graph. And then it allows for faster decision making. I can see right away there's a bar graph showing before and after, and the bar is much higher, and I can make a decision. Yes, I want to continue with this strategy because the providers are much more comfortable, and that's clearly visible from that bar chart. So when thinking through the types of visualizations that are appropriate, qualitative data, now I'm going to disseminate these slides. So this list, I'm going to go through one by one. So qualitative data, bar charts, pie charts, Pareto charts, quantitative data, histograms, box plots, scatter plots. And then in quality work, we have things like run charts and statistical process control charts. So let's start with a bar graph. This one's easy. We display counts. Our bars are proportional to the values they represent, so they're relative to one another. The scales are on the on the y-axis, and then some categories are on the y. So here, this could be years, but it could also be a comparison of provider groups that I may be looking at. If I'm aggregating these data for PMHCA encounters across the country, then I may show different states to show the differences in the different areas. I can stack bars to represent some subcategory of, so how did we get there? Here, these are adverse drug events causing harm, and they're broken up for types of drug events. I may, in fact, want to show behavioral health visits. And in that bar graph, I may want to show the subgroup of suicide, depression, all other mental health categories. And that may be the makeup of my bar that's stacked. So lots of ways that we can use bar charts. Pie charts give us an ability to think about a subcategory of the whole. So it matters less what the actual numbers are, if it matters more what the sub categories are and how they're broken up than what the actual numbers are, then that may be what I'm wanting to see. So for the example of total types of emergency department visits, this may be broken up where A represents suicide, B represents depression, AB represents anxiety, and purple represents everything else. Here, these are blood types, but you get the point here. The difference here being, again, I don't care about the absolute number, I care more about the breakup of it. If I wanted the absolute numbers, the bar chart may be a better way to represent that. Histograms show us the frequency of distribution. So they allow us to understand how many of these are we seeing in each category. And there are multiple when you've got some continuous variable. So if, for example, I wanted to say, when am I getting the most number of referral calls a day? I may want to show a histogram showing the time of day, or if I'm showing how long are calls lasting and I'm capturing that data, a histogram may be the way to show how long each call is lasting, because it gives you an idea of 30% of that, or 30 of those are lasting 54 minutes and 110 of them are lasting 60 minutes. I'm just using artificial numbers there, but gives you a sense of when you would use histograms. Box plots are also called box and whisker plots. They display basic summary information about some data distribution, but it gives you a sense of where the bulk of visits or bulk of time calls or the bulk of anything. Here, what you're able to see is where 50% of them in those in the middle box lies with the extremes at either end. So if in the question of what's the average length of your calls, and I want to see that distribution instead of the histogram, I may want to show it that way. So I'm showing what the middle, where 50% of them, where the bulk of them last, and then show the outliers at either end. And then scatter plots are a way to show association between two variables. So if here I'm showing age in months on the x-axis and body weight on the y-axis, and this gives you a sense of how they're distributed with relation, and I can then draw something linear as an interpretation. In this visit, I may, in fact, instead of age in months, I may say I'm looking at age in years, and I may be wanting to show the number of emergency department visits for behavioral health per patient, and I will get some sense of what that linear relationship looks like. If I were to speculate, I would tell you that that linear relationship, if I were comparing age in years from 0 to 6, and then had another for 13 to 16, it would be a hugely steeper curve with much higher volumes in the adolescent population, because that's where more of my behavioral health. It would not be 0 in those younger kids, even though we would like to think that. But that gives us a sense of where they're related. It also gives us a sense of where we're beginning to see patterns. So if you were to ask me the question, what do your suicidal visits look like? And I were to draw this by age, believe it or not, I would actually see some of these in the 8, 9, 10-year-olds, but I'd see the heavy dots there for number of visits per patient up in the adolescent age. A Pareto chart is a chart that allows you to arrange bars in descending order of how common a problem is. So if I wanted to put, here I see reasons for canceled visits and show the different issues. And that would, in a Pareto chart, I would want to get to 100%. And this is a way of showing what I might see in a pie chart, but it gives you a better sense of that distribution because you're seeing that as a makeup of what's most common. It helps me to get to what kinds of interventions and what kinds of key drivers do I want to be addressing. So this might be a way, for example, that you would take all emergency department visits for behavioral health in the previous example that I described and draw a different bar for how many of them as a percent add up to my 100%. That's the y-axis on the right. And then on the left, put actual numbers so that I can then relate that to numbers. So this is very useful because if I were to do this and say, what do I really want to focus my quality improvement project on? I would use the first 2 bars or the first 3 bars to say, you know, this is where I want to focus mine. And this is kind of how we landed on why suicide was going to be one of our first focus areas for ED intervention and why we created the ED Stop Collaborative, because that first bar was and second bar was where we were seeing suicides. So this, again, I'm just going to remind you that I'm just going to disseminate these, but this gives you not only a link to additional data visualization resources, but gives you a really quick sort of go-to. Like if I want to see relationships, if I want to see comparisons, if I want to see how something's distributed, if I want to see how it's composed, what's the right kind of graph to be able to visualize that work. So I hope this is useful as you think about the different measures, the different values you're collecting to say, what is the best way to display that? For our colleagues in Tennessee, if you want to show that your program, that you started early, but your program over time is showing an increased number of calls, how are we going to do that? Probably a line chart, right? You want to show this trend of increasing number of calls per month. So the x-axis would be each month, and your y-axis would be number of calls. That same kind of concept of the line chart in quality improvement is referred to as a run chart. The difference with a run chart is you have an average showing in it or a median. So what we call a measure of central tendency. It can get very complex and you can have boundaries on it to say, what do I expect to see as an upper limit and a lower limit? Those are statistical process control charts. Those are complex and I'm happy to take those offline. Or we can talk about that in a later date if anybody's interested. But this, just wanted to say, this is going to be your friend when you start talking about how systems improved. So you should all be thinking about your outcomes over time because you're doing really great work. And if it's number of volumes of calls or if it's number of ED visits that you averted based on those calls, those are ways to show in run charts how a system is improving over time. All right, so who does this work? I would say that when we think about data, you may be thinking about numbers. When we think about analytics, it's how you're looking at patterns in those numbers. And then the insights is, so how do I interpret that to action? So let's take the example of data. These are number of calls. The analytics may be me beginning to reflect that number of calls over per month. And then the insight, if I see some spike in those numbers, I then begin to understand what is the display showing me that I now interpret to a clinical change. What happened around that time? And I may want to annotate that this big spike in numbers was I brought in a different type of provider that is answering, or different type of call recipient that is doing something differently. Or if I'm measuring the length of the calls, that may be reflected on me bringing in a new psychologist who is answering calls rather than the standard algorithm that's being used to take the calls. So it may be any number of things, but the insights part is when we think about how do we take the graph that we've created through analytics and now start to apply that to what does that mean? That's the data to insights. So data, analytics, and insights. Analysts are helpful, but the key, I think, is really understanding, sorry about that. The key is really understanding what the question is that I'm asking the analyst. Am I asking the clear question for what I'm trying to achieve? And that analyst may not be able to translate the analytics to insights. That's going to be those of us involved in the project that understand the project. But I could sit with my analyst and say, okay, so this I think is related to the new type of provider that's answering calls now, and that's why those calls are lasting longer. And we may want to annotate that differently. The analyst isn't going to give you that kind of information, but they can see a spike and they can identify that in the analytics. All right. I'm going to stop there before we go into a key driver diagram and take a PMHCA specific example. Are there questions about any of these data displays? Is this useful to you, this kind of display here? And feel free to put your answers in the chat. If there are, in the dissemination of any of these slides, if there are opportunities to, that you see for you to use a different kind of chart and it's not clear from these slides, send me your question and then I am happy to send more specifics on how to use that chart. And thanks for that answer. Okay, now I'm going to move on to this, organize your project as a key driver diagram. So in a key driver diagram, we talked about a SMART aim. So let's say the SMART aim is you want to increase the percentage of suicide screening in a hospital emergency department from 10% to 90% by June of 2025. That's very specific. But my global aim may be that I want to decrease the rate of child suicide in Cuyahoga County. So that's the county that I live in. So see how the global aim is really broad, but the specific measurable, achievable, realistic, and time-bound aim has each of those 5 components to it. My key drivers to getting there are educating the staff, implementing a new tool, could be a Columbia, could be an ASQ screen, having a data process in place to measure, and then providing community resources when there's a suicide history, or immediately having a clinical intervention available when the suicide ideation is active and a plan is in the patient's mind. How do we get there? So those are your interventions. Notice how the arrows are mapped back to the key driver to help you to understand which key drivers are getting addressed by which interventions. And their training, a physician and training the licensed social worker will achieve the ED staff knowledge, would also achieve the standard screening tool use. The record being captured in a red cap for analysis would address the data process, but would also address the standard screening to know how many of those are being done. And then an intervention around follow-up discharged kids with a safety plan. Do they still have a safety plan? That would get our community resources and our data processes. You can have multiple arrows to multiple key drivers or primary drivers, or you could have multiple interventions within a category as well. So this can be rather complex or it can be rather simple. But it's really important because it creates what we call the shared baseline around the project that you're instituting and helps you to understand where the number is going to inform that. So data is really collected as we get to each of the key drivers for each of the key drivers. So think of each one of these should have a measure, and then each of those should feed into the aggregate of how are we collecting the outcome, and the outcome is going to be in the SMART aim. Have we increased the percentage of suicide screening in the hospital ED? So there, my outcome is the percentage of suicide screening. So what other aspects are should we consider? So we heard a little bit about the kind of data that you're collecting, data on the calls, data on the type of provider groups, data on comfort level, and then where would be the best places to find key data points. We talked about your own data collection, but are there other data sources when you're looking at comparisons that might be helpful? Understanding what data is your state collecting, what data is your region collecting. Is the emergency department that you're partnering with, or maybe there are multiple ones, do they have data sources that could also inform your project? Is there opportunity to cross over? So let's say you've got unique identifiers for all of your patients, and you've entered into a data use agreement with the EDs in those zip codes from where your patients are emerging. Could you look at those and say, from last year to this year, since the program, did the total number of visits into this emergency department decrease? So there you're finding a data source from the ED that you don't even have to collect, but you've entered into a data use agreement with that emergency department that would help you link your outcome directly to the data you're collecting. So lots of opportunities there. At this point, I just was wanting to leave this open for question and answer. Anything about your projects? And I see we have some chat comments. Let me open that up. Yeah, absolutely. We'll disseminate these. And I do want to, again, say that Anna and I and Jen Donovan are happy to answer any questions. If you'd like to set up some happy hours, so office hours for, you probably may want to set up some happy hours, but if you want to open up some office hours to go over the way that your data is collecting, and you want to talk about how are you visualizing your data or what is the best way, we're happy to do that. This is something we do a lot. We've got analysts on board in year 2 of our work, which we've entered into. We have written in time and technical support for analytics and data support for you guys. So let us know how we can be helpful to you. At the end of the day, you are collecting a lot of data, and the way that you show it tells the story that you want to tell, and you want to tell the most compelling story you could possibly do. So let us help you do that.
Charles, this is Anna. I just wanted to quickly add that the October 26th is, we're going to be our orientation, and we will be talking more about the year 2 and offerings that we have. So
Okay.
just keep that date. It's 3 o'clock Eastern time. Just keep that date in mind for the folks.
Okay. If there aren't any other questions at this juncture, we will end a few minutes early. Anna, when you distribute that, can you make sure that my email is on there? And if you just want to convert the slides to a PDF before you send them out, that would be great.
Will do.
Okay. Thanks everyone for joining. I hope this was helpful. Have a good day.
Thank you.
Thank
You as
you.
well.
Thank you.
Thank you.